Hello, good afternoon to everybody. Hello.
Yes, madam.
Hello, Shriman.
Yes, madam. Yes, madam.
Yes, I have joined.
Sure.
Actually, I'm very, very sorry. I was stuck in the OT.
Madam, there is a network issue from your end, madam.
Yeah. Can we start now? Shriman, can you? Yes, thank you so much. Good afternoon to everybody. Today we are here to discuss about the medical termination of the pregnancy and Amendment 2021, that is respectful abortion care. Objectives of this module is we will take a closer look at what are the new laws and what are the changes in rules. Next slide, please. So in India, unsafe abortions are a leading cause of the mortality, morbidity, and it hampers women and girls' full participation. 8% of the maternal deaths per year are due to abortions. It is third leading cause of the maternal mortality rate. Nearly 2 out of the 3 abortions performed are deemed unsafe, and nearly 50% of the pregnancy-related deaths are in women and girls under 24 years of age. Next slide, please. So when is abortion considered safe? According to the WHO definition, if it is done by the appropriate methods as well as by the trained person, then only it is safe abortion. If both the criteria are not met, then it is unsafe. It is left safe when only one criteria is met, that is either it is appropriate method or person is trained for doing that abortion. So it is only safe when both the criteria are fulfilled. Medical termination of pregnancy amendment as safe and comprehensive care mandated by WHO in 2021. So the salient features of this amendment 2021 is modification is in requirement of the provider. As we all know, what about the previous act? Requirement of the opinion of one provider for MTP up to 12 weeks of gestation. Requirement of opinion of 2 providers for MTP for 12 to 20 weeks. Now the rule has come that requirement for opinion of 1 RMP for termination of pregnancy up to 20 weeks of gestation, and requirement of opinion of 2 RMPs for termination of pregnancy by 20 to 24 weeks of gestation. So what is the potential outcome? There is increase in the number of facilities, especially in the public sector, like primary health centers, eligible for service provision up to till 20 weeks, which was previously up to 12 weeks. As well as clinics are there, they are eligible to do till MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. Now, according to 2021, enhanced the upper gestational limit from 20 to 24 weeks for special and vulnerable category of women, and increase access for the vulnerable women to safe and legal abortion services, which is defined by the violence victims, minors, among others, and further enhancement for birth defects not compatible with life on medical board consensus. And the medical board is consisting of radiologist, gynecologist, and pediatrician. Next slide, please. Shriman, please, next slide. Shriman, are you there? Yes. The Act had provision for termination of such pregnancies only up to 20 weeks, and above that, upper limit does not apply in cases of pregnancies with substantial fetal abnormalities if it is diagnosed by the medical board. So there is no upper limit. If according to the medical board, it has to be terminated, then we can terminate at any gestation age. What is the potential outcome? There is increase in the access to the safe and legal abortion services, who often seek service late beyond legal limit for the termination of pregnancy with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and court cases. Next slide, please. And the condition of the failure of the contraception was applicable only for the married woman or her husband as per previous act. But now, according to the 2021, condition of failure of the contraception to be extended for any woman, whether married or unmarried, or her partner. So the potential outcome is increased access to safe and legal abortion for any woman, irrespective of marital status, especially with upcoming changes in the legal age of marriage, which is now 21 years of age, which is an important advancement for increasing access to safe abortion. So now any woman, whether married or unmarried, can go for termination of pregnancy. The Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except under authority of law. Name and particulars of a woman whose pregnancy has to be terminated shall not be revealed except to a person authorized by any law for the time being in force. The potential outcome is increase in the privacy and confidentiality of the abortion seekers, increased demand, but need to safeguard rights and dignity of the woman simultaneously, and provide respectful bias-free services, including counseling as well as contraception. So name and particulars of the woman should not to be exposed to the other persons. We have to maintain the dignity and confidentiality. So we have discussed the slide that we have to maintain the confidentiality, and ground of failure of the contraception has been extended to the woman and her partner as well. Next slide, please. So what are the rules under MGP Amendment 2021? It defines special category of women who are eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. What are the norms for the RMP, whose opinion is required for termination of pregnancy at different gestational ages? What are the powers and functions of the medical boards, OBG and PEDS plus radio when available, formed for each state and mandated to provide timely evidence-based decision? Next slide, please. So what are the rules under MTP Amendment 2021? What are the special category of women who are eligible for magical termination of pregnancy between 20 and 24 weeks? Number one is the survivors of the sexual assault, rape, and incest. Secondly, women with the pregnancy in humanitarian settings, emergency situations, as declared by the government. Thirdly, change of the marital status during the ongoing pregnancy, that is, she is widow and divorcee. Fourth is women with the physical disabilities under the Disability Act, major disability as per criteria of the Disability Act. Fifth is if she is mentally sick, including mental retardation. Sixth is minus less than 18 years. And seventh is the fetal malformation that has the substantial risk of being incompatible with life, or if the child was born, if it would suffer from such physical or mental abnormalities to be seriously handicapped. In all these seven situations, we can go for termination between 20 to 24 weeks of gestation. So norms for the RMP according to 2021 is medical practitioner assisted in 25 cases of MTP, of which at least 5 she has done independently. A medical practitioner who has completed 6 months of house job and obs-gynae, who holds a PG degree or diploma in obs-gynae, who has experience of at least 1 year in the practice of obs-gynae. As we have already discussed, one RMP opinion till 20 to 24, medical board beyond 24 weeks of gestation. Next slide, please. Next slide, please, Chairman. This has been discussed. We want next slide. Under the Amendment Rule 2021, additional category of provider has been added for termination up to 9 weeks with medical methods. RMP with experience in the practice of OBG at any hospital for only 3 months. This is a good one. Or training with performance of 10 cases of MDP by medical methods under supervision of an RMP in a hospital established or maintained or a training institute approved for this purpose by the government only. So only 3 months is required experience in OBG at any hospital. This is a good one. Norms for the RMP. Next slide, please. So till 9 weeks experience and training requirement for the RMP experience at any hospital 3 months. 10 cases of MTP by MMA under supervision of our RMP. Secondly, has assisted in the performance of 25 cases of medical termination and at least 5 have been done independently in a hospital. Third is PG degree or diploma in OBG. Fourth criteria is 6 months of house surgency and obs-gynae. Fifth is 1 year in the practice of OBG. That person is eligible to do that 9 weeks termination of the pregnancy, and opinion of one RMP is required only. Next slide, please. So till 12 weeks, experience and training requirement again, assisted RMP in the performance of 25 cases of MTP. 5 has been done independently, same criteria. PG degree or diploma in obs-gynae, same criteria. Third is 6 months of house surgency in obs-gynae. Again, same. Fourth is the 1 year in the practice of OBG. Again, opinion of one RMP is required till 12 weeks of gestation. Next, please. Beyond 12 weeks till 20 weeks, experience and training requirement for RMP. Again, one RMP, PG degree or diploma. Second is 6 months of house surgency in obs and gynae. Third is 1 year in the experience practice of the obs and gynae at any hospital. Next, please. So till 20 weeks, we are required only one RMP, but beyond 20 weeks till 24 weeks, experience and training requirement for RMP criteria is again PG diploma in obs-gynae, 6 months house surgeons in obs-gynae, third is 1 year in the practice of OB-GYN, and but here the difference is only opinion of 2 RMPs is required till 24 weeks of gestation. Beyond 20 weeks, we are in need of 2 RMPs to do the medical termination of pregnancy. But the criteria, PG or diploma, 6 months house surgency, 1 year in the practice of OBG at any hospital, that person is eligible to do the medical termination. Next slide, please. So beyond 24 weeks, experience and training, again PG degree diploma 1 year in the practice of OB/GYN at any hospital. But here, opinion of the medical board is required for termination of the pregnancy. For the procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling at an approved place. Next, please. So composition of the medical board is one gynecologist plus one pediatrician plus a radiologist or sonologist. So even in the diploma sonologist, that person can be in the composition of the medical boards, either radiologist or sonologist. Next, please. So now coming to the powers of the medical boards, this is very, very important to allow or deny termination of pregnancy beyond 24 weeks of gestation period, only after due consideration and ensuring that the procedure would be safe for the mother at that gestational age, and whether the fetal malformation has substantial risk of it being incompatible with the life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped, who opt other specialists in the board and ask for additional investigations if required for deciding on the termination of pregnancy. As we have already discussed, that if other specialists, like we were having one case of the cardiac problem where we accompanied the cardiac anesthetist also during medical termination of pregnancy. So Foxy, with the ministry guidance and WHO support as part of the RAC, can operationalize and host medical board information on website. Next, please. What are the functions of the medical board? Number one is to examine the woman, her reports, who would approach for medical termination of pregnancy. Secondly, provide the opinion of the medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. So board has to give their opinion within 3 days whether to proceed for the termination or to reject. Thirdly, to ensure that the termination procedure, if advised by the medical board, is carried out with all safety precautions along with the appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. So board opinion within 3 days and termination procedure within 5 days of the receipt. Foxy has an important role to play in ensuring there are functional medical board in every state as is stated in MTP Amendment 2021. Next, please. Next, please. Next, Shriman, please.
This is the last PPT, ma'am.
Thank you so much. So we are here to discuss about the respectful abortion care, and a really nice step has been taken by WHO as well as the Foxy is doing such hard work so that we can go for the respectful abortion. We have to maintain the dignity, confidentiality, and we have to give the respect to the patient, as well as we have to take into the consideration all the legal things which has been made by the guidelines. So it is an act, we have to follow the act. Otherwise, we all know what will happen if we are not following the rules and regulations according to the MTP Act. Thank you so much for patience hearing.
Good afternoon, everyone. I'm Dr. Rekha from Shimoga. Actually, I was supposed to handle the last topic, but I shall be taking the second topic since the speaker has not yet logged in.
Should I share the screen, ma'am? Or do
Yeah,
you have
I have shared.
Okay.
Can you put up the slides?
Yes, ma'am.
Okay. Will you be sharing the slides to me?
Yes, ma'am. I'll do.
Okay.
Rekha, ma'am, you can start now.
Yeah. Today I'll be speaking about safe abortion updates in technology. Next slide. So in this topic, we'll be discussing about existing guidelines, pre-abortion assessment, medical methods of abortion, and various surgical methods of abortion. Next slide. So the guidelines of WHO on safe abortion mainly concentrates on making it safe, respectable, and so calls it as comprehensive abortion care. Next slide. In 2012, there were technical and policy guidance for health system. In 2014, clinical practice handbook for safe abortion came up. In 2015, health workers' role in providing safe abortion care and post-abortion contraception was stressed upon. In 2018, medical methods of abortion were introduced. In 2019, WHO consolidated guidelines on self-care intervention for health. So this is the roadmap to WHO safe abortion guidelines. Next slide. Ministry of Health and Family Welfare National Guidelines on Safe Abortion. The prior law underwent a lot of amendments. The rules changed and a lot of amendments were made on 24th September 2021. So 2021 was historic in means of making MTP a comprehensive care, and it was made mandatory by law. Next slide. All the guidelines have three key areas in the management of abortion, which is to be conducted safely. Number one, pre-abortion care. Number two, abortion care methods. Number three, aftercare and follow-up, which includes post-abortion contraception and counseling. So this involves medical history, physical examination, laboratory and other investigations, and discussing the contraceptive options. If the woman chooses to have an abortion, she should be allowed to choose from the available methods that are appropriate for her based on the duration of her pregnancy and her medical condition. Next slide. Coming to the pre-abortion assessment and counseling. There are four components of pre-abortion assessment for women seeking first trimester abortions. That includes detailed history taking, general physical and pelvic examination, laboratory and other investigations, decision-making information on abortion procedures, and counseling. Next slide. Gestational age determination by LMP can be done, or by physical examination can also be done. Coming to pregnancy dating by physical examination, we all know by noting the height of the uterus, we can calculate the period of gestation. What are the limitations of calculating gestational age by LMP? All of us very well know it. The causes wherein there is fallacious increase in uterine size, like in presence of fibroids, multiple gestation, obesity, molar pregnancy, or marked uterine retroversion. Sometimes our uterus can be smaller than expected. So in conditions like when the woman is actually not pregnant at all, inaccurate menstrual dating, ectopic pregnancy, or abnormal intrauterine pregnancy. Our uterus can be larger than expected, as in inaccurate menstrual dating, multiple gestation, fibroids, molar, as I discussed earlier. Next slide. What are the pre-abortion investigations? Routine lab tests are not a prerequisite for abortion services. So this is to be noted. Tests that may be performed as per individual risk factors on findings of physical examination are pregnancy test if pregnancy is not confirmed. You should do a hemoglobin or hematocrit if you suspect anemia. RH testing, where RH immunoglobulin is available for RH negative women. HIV testing, STI screening, and other lab tests as indicated only by medical history. So all the routine investigations are not necessary for you to conduct an abortion. Ultrasound is said to be not necessary unless to diagnose pregnancy of uncertain origin, uncertain location, or whenever you are suspecting ectopic or missed abortion. Next slide. In pre-abortion counseling, what do? You ask thoughts about terminating the pregnancy and the reason for termination. So you need to know or document a proper indication for MTP. Inform that early abortion is safe and importance of a trained provider performing the procedure for safety. Available methods of abortion, risks and warning signs associated with the abortion method. And without contraception, we should tell that she can return to fertility very soon, as early as 10 to 14 days after an abortion. Resumption of her normal activities, including sexual intercourse and any other follow-up care. And you need to document informed written consent, which is very important. Decision to accept post-abortion contraceptive should also be mentioned. But please note that even if she is not willing for contraception, she will be provided with the abortion services. Next slide. Clinical management of abortion. So what is abortion care? We know that less than 12 weeks, we can either go for MMA, medical method of abortion, which is very effective up till 9 weeks. Is it not? So after that, 9 to 12 weeks, suction aspiration or MVA, manual vacuum aspiration, can be adopted. So less than 12 weeks, the global recommendations are mifepristone and misoprostol, MMA, or misoprostol only, or vacuum aspiration. After 12 weeks, the global recommendation is again mifepristone and misoprostol only, and then dilatation and evacuation. Please note that dilatation and curettage is not compulsory for all the cases. Only if you're doubtful that there are retained products of conception, you need to do DNC. Otherwise, you're making the situation worse by creating Asherman syndrome and introducing sepsis. So you're spoiling her future fertility if she's desirous of future pregnancies. So dilatation, curettage routinely should not be performed. So Government of India recommendation, please go back to the previous slide. Previous slide, please. Yeah, Government of India recommendation is up till 9 weeks, you have to give only medical method. Medical method is mifepristone 200 mg orally, then wait for 24 to 48 hours. Then you can give misoprostol 800 microgram, either sublingual or buccal. Okay, and up to 7 weeks, it is very, very effective. Again, same dose. Mifepristone 200 mg oral, wait for 24 to 48 hours for the mifepristone to act. Then you can give misoprostol 800 microgram, sublingual or buccal, or you can also keep it per vaginal. Next slide, please. Clinical management of abortion. Methods of first trimester abortion include either medical methods or surgical methods. Surgical method is, as I told you, 9 to 12 weeks. We prefer MVA. Next slide, please. So let's see how this mifepristone and misoprostol act. Mifepristone is an antiprogestin, inhibits action of progesterone. It interferes with the continuation of pregnancy. The initial oral dose of mifepristone is followed by misoprostol, a prostaglandin even analog. Misoprostol causes cervical softening, causes uterine contractions, and expulsion of products of conception. Next slide. What are the advantages of tablet misoprostol? Previous slide. Okay, the slide is not showing up. The advantages of misoprostol is: one, it will ripen the cervix; second, it will initiate uterine contractions; and third, it will expel the fetus. Protocols for mifepristone and misoprostol, friends, you already know this. On day 1, we give mifepristone 200 mg orally. And if the patient is Rh negative, we have to give anti-D 50 microgram at the time of administration of mifepristone itself. So 48 hours later, we call her. This is a printing error. This is misoprostol administration. Up to 7 weeks, we give 400 microgram misoprostol, sublingual, buccal, vaginal, or oral. Or from 7 to 9 weeks, we can give 800 microgram sublingual, buccal, or vaginal. In addition, if the patient is having too much of pain, we can prescribe analgesics like ibuprofen. If she is having nausea or vomiting, we can prescribe her antiemetic like promethazine or metoclopramide. If it's too much, on them also. And at the same time, when you're prescribing misoprostol, you have to also offer contraception counseling. Within day 15, you have to ask her for follow-up, confirm, and ensure completion of the procedure, and offer contraception if already not done so. Next slide. What are the characteristics of different routes of misoprostol administration for first trimester abortions? Orally. Orally, pills is swallowed. It is recommended up to 7 weeks for first trimester abortions. The side effects include, obviously, it has to go through the gut and hence causes vomiting, diarrhea, nausea, fever, and chills. So you can just give symptomatic treatment for these side effects. Buccal, pills are placed between the gums and the cheek and swallowed after 30 minutes. So this this mode of administration should be kept in mind. It is not kept just below the tongue. The pills are placed between the gums and the cheek and swallowed after 30 minutes. There'll be more fever and chills than with the vaginal route. Sublingual, pills are placed under the tongue and swallowed after 30 minutes. This is called sublingual. Increased fever, chills, diarrhea, and vomiting compared to the vaginal route. But however, this is the fastest onset of action and highest plasma concentration levels. Vaginal, pills are placed in the vaginal fornices, deepest portions of the vagina, and the woman is instructed to lie down for about 30 minutes. This is the most commonly used method. Pill fragments may be visible when you check her after a few days, and it has lowest rate of side effects. Next slide. So this is a picture demonstrating buccal administration and sublingual administration. Sublingual, we are all aware of. Buccal is to be kept in mind. Next slide. So what are the WHO drug regimens dose schedule for medical abortion? Recommendations, it's the same. The same thing is represented. Vaginal bleeding for 2 weeks is normal after medical abortion. So you need to counsel her that minimum amount of bleeding is permissible, but only if she feels giddy or feels weak or has too much of bleeding, then she needs to come back. Otherwise, she needs to see you at the end of 15 days. Such spotting can last up to 45 days in some rare cases. Next slide. Provision for MMA services. Services should be available at the primary care level with referral systems in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortion. Counseling and testing for STIs, especially if you suspect high-risk behavior. Abuse support services, psychological or social services, or other specialist health or medical services. Provide iron tablets for anemia if needed. So this is an opportunity to treat anemia as well to do contraception counseling. Provide any necessary pain medications and provide emotional support if required. Next slide. Next slide. So what do you do in the follow-up care? Routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered if the patient has not accepted contraceptive counseling. So in the follow-up, you can give contraceptive counseling and services, emotional support, or address any medical concerns. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess success of abortion. Next slide. Assess woman's recovery and ask for any signs or symptoms of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptoms experienced since the procedure. Perform a focused physical examination for any complaints. Assess woman's fertility goals and need for contraceptive services if not provided earlier. Next slide. So the summary of medical method of abortion. Next slide. First visit, what to do? History taking, physical and pelvic examination, confirm eligibility of the patient, 7 weeks, intrauterine pregnancy, tablet mifepristone 200 mg orally, offer anti-D if she is Rh negative. How much? 50 micrograms since she is in first trimester. Then tell the woman to return for misoprostol administration after 2 days or 48 hours. Please take the contact address and phone number of the facility or the center where she can go in case of any emergency. Record experience of any side effect on the MMA card. 3% of women may expel completely with mifepristone alone, but misoprostol schedule should be completed. Next slide. Second visit is on day 3. What do you do then? Give misoprostol 400 micrograms sublingually, buccal or vaginal or oral. Observe for 4 hours. You can give analgesics like ibuprofen 400 mg and give contraceptive options. Then tell the woman that the mean period of bleeding is 8 to 13 days. Possible side effects are nausea, vomiting, diarrhea, headache, fever, dizziness. Report in case of excessive bleeding, pain, abdomen, and fever. Report if there is no bleeding 24 hours after misoprostol, and consider giving additional dose of misoprostol. 75% of women abort within 4 to 6 hours after misoprostol administration. What to do? Pelvic examination to ensure the completion of abortion on the 3rd visit. This is the 3rd visit on day 15. What do you do? Pelvic examination to ensure the completion of abortion. Give contraception counseling by explaining various options, hormonal methods, condoms, IUCD, sterilization after the next cycle. Tell the woman about immediate return to fertility as early as 10 to 14 days. Report back if there are no periods within 6 weeks of completion of the abortion process. Ultrasound is not mandatory. It's done only if examination does not confirm the completion of procedure. Next slide. Next slide. Next slide. Coming to the side effects and complications, pain. Be very respectful and communicate non-judgmentally. Do not neglect her pain. Give verbal support. Give adequate counseling. Support the person. As I told you, Brufen 400 mg will help. Persistent pain with failure to respond to these drugs for several hours warrants evaluation of other causes like ectopic, infection, or incomplete abortion. Nausea and vomiting is usually self-limiting. You can reassure. If it's severe, you can give antiemetics. Diarrhea is also self-limiting. Just reassure her. If like it's bothering her, you can give this sporolac and such things. Infection confirmed by physical examination and start antibiotics. Next slide. Action for failure or incomplete result of MMA. Failure of MMA, what do? You can either repeat MMA or offer vacuum aspiration directly. An incomplete result of MMA means what? You observe unless heavy bleeding, you repeat misoprostol or offer surgical method of evacuation. If the heavy bleeding continues, bleeding is resolved, uterus normal size, abortion is complete. Next slide. What do you do when there's excessive bleeding PV? A woman presents with excessive bleeding PV, bleeding more than her menstrual cycle. This I'm telling you, in those 14 days in which the patient would have gone home, if she comes back with following symptoms: bleeding more than her menstrual cycle, soaking 2 pads in 1 hour or for 2, bleeding decreases over time, you need not have to do anything. If bleeding decreases over time, then routine care, keep a watch on her vitals and bleeding PV, and she can go home. Suppose a bleeding does not decrease over time, then watch her vital signs, do a PV examination, and look for product of conception in the cervical canal. It could be an incomplete abortion, and do digital evacuation. Okay, if the woman becomes stable and the bleeding reduces, what do? Just observe and monitor her vital signs, bleeding PV for 1 more hour. But if the bleeding doesn't come down and it continues, ultrasound is indicated to look for minimal decidual bits or products of conception and decidual bits, or sometimes the pregnancy would have just continued. So if there are minimal decidual bits, then you can just wait and watch. If the retained products of conception is less than around, say 1.5 centimeter, you can just wait and watch. If the products of conception are seen and decidual bits are seen, but the woman is stable, you can again go for medical methods, misoprostol 600 microgram oral. But if the woman is unstable, not stable, there's a tachycardia, hypotension, better evacuate fast by doing vacuum aspiration. If the pregnancy has continued, then now you can go for vacuum aspiration. Next slide. Recording and reporting for MMA. Since MMA comes under the purview of the MTP Act, the documentation is similar to that required for the vacuum aspiration procedure. It is mandatory to fill the following forms. As we all know, Form C for consent form, Form 1 is RMP opinion, Form 2 is monthly reporting form to be sent to the district authorities, Form 3 admission register for case records. Next slide. Methods of first trimester abortion, surgical methods. Manual vacuum aspiration. Next slide. Surgical abortion methods in first trimester. Vacuum aspiration is the recommended technique of surgical abortion for pregnancies up to 12 weeks. That is 9 to 12 weeks. WHO recommends manual vacuum aspiration, that is MVA, as the safest method. The procedure should not be routinely completed by sharp curettage, as I told you earlier. Next slide. What are the vacuum aspiration methods? Everybody should be confident of using MVA. Procedure of abortion performed is same regardless of type of vacuum used. Manual vacuum aspiration is done by using a handheld aspirator used to generate vacuum. Aspirator is attached to cannula of 4 to 12 mm in diameter. Cannula can be used in multiple settings, including those without electricity. It's the easy grip cannula size corresponds with weeks of gestation. You use 8 mm cannula for 8 weeks, 10 mm cannula for 10 weeks gestation. So this is the cannula with an aperture. These are plastic cannulas with dots on it. There's a wing, there's a base. There's an easy grip cannula. This is the assembly of MVA. There's a cap, there's a wall button. First, you press the wall buttons and then pull the plunger handle to create vacuum. And then you insert the cannula and then fix the syringe with vacuum intact and then start curetting. Okay, to then after the curettage, once the suction is complete, then you remove it and release the valve buttons. Next slide, please. This is electric vacuum aspiration, wherein the suction cannula is directly connected to your suction machine. The suction machine you regularly use for your cesarean section. So an electric pump is used to generate the vacuum here. It can accommodate cannula of manual vacuum aspiration with correct size tubing. Next slide. So for this, cervical priming is vital. It may be considered for women with a pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. So there's no forceful dilatation. It's always better to prime the cervix before you do surgical abortions, even in first trimester. Cervical priming can be done with oral mifepristone 200 mg, 24 to 48 hours in advance, or misoprostol 400 micrograms sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 microgram administered PV 3 hours prior to the procedure, or laminaria tent placed intracervically 6 to 24 hours prior to the procedure. Next slide. How do you manage pain while doing vacuum aspiration procedures? It's an important component of quality abortion care. So pain management is the patient should not be writhing in pain or shouting in pain when you're doing MTP. So this is an important component of this quality abortion care and respectful abortion care. We have to reduce the pain and anxiety and make the woman comfortable. The two components of pain management are non-pharmacological and pharmacological. Next slide. Non-pharmacological includes providing psychological support, explaining each step to the woman in advance, performing the procedure gently and smoothly, encouraging the woman to relax and breathe deeply. Next slide. So what are the drugs, medications you can give? Anxiolytics, general anesthesia, like short GA, diazepam 10 mg orally 1 hour prior to the procedure, or 2 to 5 mg IM 20 minutes prior to the procedure, the effect of which will last for 6 hours. She might feel giddy and a little disoriented. The cervical dilatation, pain can be mitigated with lignocaine, 10 ml, 1% lignocaine, local anesthesia. You can give paracervical block, or you can give analgesic like ibuprofen, 400 mg 1 hour prior to the procedure. So this effect of paracervical block will last up to 1 hour. Then uterine cramping, pain due to uterine cramps can be taken care of by ibuprofen, 400 mg given 1 hour prior to the procedure. This will act for 6 hours. The main side effect of brufen, as we all know, is gastritis, NSAID. That's why it called this gastritis. Next slide. Steps of MVA. Next slide. Yeah, as I told you, close the wall buttons and pull the plunger. So it creates a vacuum. Then prepare the woman. Ensure pain control, paracervical block or ibuprofen. Ensure pain control is given at the appropriate time. Ask the woman to empty her bladder. Step 3, perform cervical antiseptic preparation. As I told you, paracervical block. This is how you do pain control. Then dilate the cervix with serial dilatation using Hegar's dilator. Insert the cannula and later fix your syringe. Next slide. Next slide. So suction of the uterine contents, how do you do it? Withdraw the cannula 1 to 2 centimeter away from the fundus inside the uterine cavity so that you don't perforate the fundus. Rotate the cannula in from 10 to 2 o'clock position with smooth, gentle motion. Then finally, release the vacuum button on the aspirator. Next slide. What are the signs that the uterus is empty? Friends, we all know red or pink foam without the tissue passing through the cannula. There will be gritty sensation of the surface of the uterus. Cervix starts gripping over the cannula. Uterus contracting around the cannula and the increased uterine cramping. Inspect the tissue you have aspirated. And what are the concurrent procedures? Sterilization, contraceptive procedures. If she wants IUCD insertion, go ahead with it. If she's willing for sterilization, you can do it concurrent with the MVA. Instrument processing. Instruments should be soaked in chlorine solution. Assists disinfection. Helps remove tissue and body fluids. Next slide. Next slide. So what is the post-procedure care? Monitor her for any complications and provide management as needed. She may leave the facility when she is stable and meets the criteria for discharge. Ensure that the woman has all necessary information and medications prior to leaving the facility. Document all the outcomes of the treatment, including any adverse events, in the facility register and client's record card. Next slide. Aftercare, I've told you management of abortion complications, which may include incomplete abortion, infection, bleeding, ongoing pregnancy, provision of contraceptive information and offer contraceptive counseling and methods, assessment of any other sexual and reproductive health needs that may require additional care, follow-up, no routine follow-up unless meso alone regimen is used. Next slide. Next slide. In summary, India has made historic progress in improving access to safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in the context of amended law. Along with safety, we also need to focus on respectful abortion services. Every client, either public or private, should have an opportunity to get informed, to get educated, and to get equipped with proper information on contraception counseling. Next slide. So, unsafe abortion being the fifth largest cause for maternal deaths, I think this program, this initiative is very important, and let's hope that all of us will practice safe abortion practices, and unsafe abortions will no longer be the cause of maternal mortality in India. Thank you so much for the opportunity.
Hi, Sriman. Hello, everyone.
Hi, madam.
Am I audible?
Yes, yes, ma'am.
Yes, ma'am.
It's my turn now. Sriman.
Yes, madam. I'll share the screen.
In between, it was not audible.
Yeah. Yeah.
Now it's
Hello.
audible.
Yeah. Hello, everyone. Sorry for joining a little late. Yeah. I congratulate you all for participating in this program. I'm Dr. Swarupa from Mancherial. Today, I'll be addressing the second topic of RAC program. Yeah, Sriman, can you
Madam,
please
third
share the
topic,
slide?
madam. Third topic, madam.
It's third topic. I'm sorry. Yes, third topic. Thank you. Please share the slides. Talking about safe evidence, rights, respect. Next slide, please. Sriman, next slide. One second. Just give me a minute. भले time की जरूरत है बस. Rashid. Yeah, this module aims to define respectful abortion care as per the WHO standards. It highlights how norms and stigma affect the services. It provides WHO saver resources for RAC. Next, please. Momentum has been created regarding this RAC. The law has changed. As per this, the dissemination needs association and OB-GYN provider support. Online training is possible because of this COVID situations. Everybody now is favoring the online training, and respectful abortion care through this online is reaching most of the providers. Foxy being the largest provider base for this abortion care. The medical management of abortion uptake has increased. It is early, safe, and ensures no PCPNDT conflation. Patient safety, respect, and quality matters more than ever, and we all have a role to play. Next, please. What is respectful abortion care? Adopted from respectful maternity care recommended by the WHO, respectful abortion care refers to the care that maintains the safety, dignity, confidentiality of the patient and ensures freedom from harm and mistreatment, and it enables informed choice and continuous support during and after all types of abortion. Next. What is respectful abortion care? In simpler terms, respectful care means you as a provider or as a patient treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, pregnancies, miscarriages, abortions, etc. If you ever feel that something isn't right, please speak up. As a health professional, it is our duty to listen and support. Communication is the key of this respectful abortion care. Next, please. What are the norms and stigma? Next.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
Yeah, stigma and norms perpetuate disrespect and abuse. It is physical abuse, like slapping, intimidating physically. Freedom is a right of every woman from all harm and ill treatment. We need to fight it. Verbal abuse, like non consented care, shouting, screaming. Sexual abuse, abuse of power, and discrimination. Right to information, protection under laws, MTP, POXO Act, informed consent, and refusal, and respect for choices and preferences, dignity and quality of care. The failure to meet professional standards of care, right to get the health care, poor rapport between women and providers, health system, conditions and Sriman, I can't see it properly. Yeah. Health system conditions and constraints. See, whenever a patient or a woman comes for a abortion care, we have to treat her with proper respect. We have to address her physical abuse or verbal abuse, sexual abuse, give her confidence, and our dignity should be maintained. At the same time, the confidentiality should be maintained, and we have to give the required support. Next, please. Domains of respectful abortion care. There are 12 domains, like being free from harm and mistreatment. We have to maintain the privacy and confidentiality. Preserving the woman's dignity is the utmost important. Respecting women's choices. We have to tell her what are the various methods available, and we have to give her all the options before deciding the method. Engaging with effective communication. We have to be very soft when talking to the woman who has come for this care, because she might be mentally disturbed. We have to take into account all her physical, mental status and give her the required support. It is possible only through the soft skills. Providing information and seeking informed consent. Give all the options of the methods and the choices, and then take an informed consent from the patient. Ensuring continuous access to support. This support system, whatever the healthcare provider is giving, it is a continuous system where the patient can approach you in case she has any untoward bleeding or any other complication at any hour of the day. Enhancing quality of physical environment and resources. The environment should be amicable to the patient. Providing equitable abortion care. It should be given equitably, and availability of competent and motivated providers. The healthcare providers should be competent enough, and they should be motivated to give this respectful abortion care. The provision of contraception advice and commodity security. Like whenever the woman comes in contact with a healthcare provider, they should discuss about the contraception, and this is how we can prevent the unwanted or the unplanned pregnancies and can avoid abortions also. Continuity of care and counseling. And once a patient comes to you and gets a treatment for some abortion or something like, we have to counsel her so that she doesn't end up with some such type of unwanted or unplanned pregnancies next time. It is time to, it's not clear, Sriman, time to strengthen implementation. Sriman, the visual is not clear.
Might be an internet issue, madam, from there.
Yeah. 1 second, Sriman. Just a minute.
It's visible, madam.
1 minute. No, yeah, it is visible. 1 minute. I need a minute. 1 minute. I'm sorry for this. Just a minute. No, again, it is blurred. Yeah. Yeah, it is time to strengthen the implementation. One provider, more responsibility. So we have to counsel about the procedures, the contraception methods, referral, and we should also tell them about the methods available. The second is expands the eligibility criteria. Earlier, as per the MTP Act, previously it was only up to 20 weeks. Now, because it is extended up to 24 weeks, we have to counsel the young people, survivors, even the unmarried person, irrespective of her age, can be offered this care. But mind it, below 18 years, they have to be registered under the POXO Act. Sriman blurred. Yeah, 24 weeks for special cases, about 24 weeks, up to 24 weeks.
Ma'am, we can't hear you.
Hello.
Yes, madam.
Hello.
Yes, ma'am. Yes, ma'am.
Are you able to hear me?
Yes, madam.
But my visual is gone. 1 second, I'll just log back. Yeah, I'm here. Yes. 1 second. I'm sorry, really lots of disturbance. Yeah, from 20 to 24 weeks, it is a special case. Need for sensitivity and judgment. I can't see it. Sriman. While between 20 to 24 weeks, timely service has to be provided. Prioritizes confidentiality and safety. Respect begets respect. So as providers, we need to be mindful of socio-cultural aspects. Name and other particulars of any woman seeking abortion to be confidential, except to a person authorized in any law for the time being in force. And the ground of failure of contraception has been extended to women and her partner too. So respect, quality, and dignity at all types of abortion is the need of the hour. Next, please. Yeah, the video, please. Yeah, guide to avoiding stigmatizing
How
language.
to talk about
Sriman will play
abortion.
it.
A guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Hello. This was regarding the safe abortion values, that is the evidence and right. This is the saver toolkit. Am I audible?
Yes, ma'am.
Yes.
You're audible.
Yes, Sriman, please.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Yeah, there are games like self-paced game like Cross the Line, Personal Compass. These are all online games where there's person understands the safe abortion values, evidence and rights, the SAVOR modules of the WHO. Next, please. From 1970, we have traveled through unsafe abortion to safe abortion in 2000s, and now in 2020s, we are going through the respectful abortion. Every woman has a right to undergo abortion whenever needed, and we should support as health providers, giving her the required information, equipping her with the required methods, taking her consent, and educating her regarding the complications, and also the round-the-clock service when needed, and support should be given by the health providers. According to WHO organization, restricting access reduces the number of unsafe abortions. True or false? It is false, because once we cut off the access, they will try to get it done through other means, right? They will land up with unsafe abortions, more of unsafe abortions. So they have to have a free access to the respectful abortion. Next. And the 1 second, Sriman, please, the previous slide. Yeah, when is the abortion considered safe? So it has to meet the 3 criteria, that the place, the provider, and the process. 3 should be in a safer condition. Like, it will be safe when it is done by appropriate methods and by trained persons, and it is less safe when done by after meeting the criteria and by trained persons. But if it is done by inappropriate methods or untrained person, it is unsafe. And it is totally unsafe when the criteria is not met of the appropriate methods and the trained persons. So safe abortion is to be sought after. Next. Yeah, 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Is it true or false? So I say it is no, because a 30-year-old woman, it is her choice whether she should continue the pregnancy or not. Even a widow, whether she should continue the pregnancy or not. If she decides to undergo an abortion because it is about 20 weeks, so there are two. This is where the criteria comes. Up to 20 weeks of gestation, one registered medical practitioner can do the MTP. And if it is between 20 and 24 weeks, here, as it is in our case, the widow, when she approaches, she has 22 weeks. So at 22 weeks, she needs 2 RMP's opinion, and then after they agree for the MTP, then only she can undergo MTP. And if it is above 24 weeks of gestation, which is provided by the amendment of 2021 MTP Act, we should approach the medical board, and then after the medical board gives a consent and agrees, then only we can do the MTP after 24 weeks of gestation. It is very limited to special conditions and cases. And birth defect, there is no gestation limit, but the board should give the permission. Next, please. So In India, abortion is legal. Let us make it safe and respectful. Thank you. Thank you for the patient listening. If there was lots of disturbance, I'm sorry for that. Thank you, Sriman. Sriman, our next speaker.
Rekha ma'am only, ma'am.
Hello.
Hello. Hi,
Yeah,
everyone.
ma'am.
I'll be
In case of birth defects, what is the cutoff limit? Ma'am said there is no limit, but we have to take the permission of medical board.
Yeah, after 24 weeks, you need to take the permission from the medical board. In case
In
of,
case of birth defects.
yeah, like
Okay.
anomalies that are not compatible with life.
Okay. Thank you, ma'am.
Minor defects like clubfoot and all, you know, you don't terminate, right?
Yeah.
Yeah, fine.
Thank you, ma'am. Thank you.
Please share the screen, the slides. Yeah, now I'll be speaking about pre and post abortion family planning counseling and how we need to leverage technology for referrals and online consultations. Next slide. What do you mean by counseling? It's a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. And here the trained person is we gynecologists. Next slide. Pre and post-abortion counseling includes, it's an integral part of comprehensive abortion services. It's as important as the procedure. Women may need help in decision making. Wherever needed, the spouse should also be counseled. Next slide. Pre-procedure counseling plays a critical role. Help the woman to decide about termination of pregnancy. Help the woman to choose the method of termination. Ensure delivery of complete information about the procedure. Help woman to adopt a contraceptive method. Next slide. While doing so, please ensure privacy and confidentiality. Be non-judgmental and be sensitive. Establish rapport. If she has made up her mind for termination of her pregnancy, assess her for the procedure. Use simple language and allow the woman to clarify her doubts. Next slide. You should make her realize his quick return of fertility as early as 10 to 14 days post-abortion. And this is an opportune time for contraceptive acceptance. The health benefits and better future pregnancy outcomes should be explained to the patient. A minimum 6 months gap is advised before next pregnancy. 90% of abortion-related maternal mortality can be prevented by ensuring contraception. MTP has now become, a means of contraception. The ladies get repeatedly pregnant and come for MTP. This has to be corrected by applying peri-abortion family planning counseling, and this is very important, as I said earlier, as important as the procedure. Next slide. Pre-abortion FP counseling. When to start? At the very first visit, that is at the very first consultation. If the patient is in grief or emotionally unstable, you can delay. What to counsel? You have to counsel about the return of infertility, quick return of quick return of fertility as early as 10 days or 4 weeks. Help with choices of contraception, method-specific counseling, and whenever you suspect high-risk behavior, counsel her regarding the same. If the woman is not willing for any contraceptive method, please do not refuse MTP. She has the right to MTP irrespective of whether she wants contraception at the same time or in future. Pre-abortion FP counseling. Yeah, this is done. Next slide, please. Yeah. You have to assess the suitability for post-abortion contraception. The general guiding rules are you have to make sure that the abortion process is complete. There's no existing infection. There's no injury to the genital organs. Chances of fresh pregnancy are ruled out. Next slide. Post-procedure counseling ensures woman has understood precautions and care needed during post-abortion period. It's an opportunity to counsel for contraception in case not previously accepted. It will reinforce the need for continuing the use of contraceptive method that she has already chosen. Like in example, immediately after abortion, you would have inserted IUCD, encourage her to continue IUCD if she has got minor symptoms like spotting, pain, abdomen, etc. Post-procedure counseling, continue to ensure privacy and confidentiality, reassure her in case of any problems, repeat the information about post-procedure care and danger signs. Next slide. If she has already opted for a family planning method, appreciate it, give immediate care as an IUCD and MPA concomitant with your abortion. If she's already been taking oral pills or the pregnancy happened because of missed pills, ask her to continue the same. Follow protocol, continuity, and then you can make use of cards in order to educate her. If she has reproductive intuition, ask her to continue the contraceptive method she has accepted. If she is undecided, allay her anxiety, tell her the importance of immediate adoption and the continuation of the method she has already chosen, extended period of adoption, couple counseling, and emergency contraceptive pills. Next slide. So we know the various methods. Condoms can be used as soon as the sexual activity is resumed, both in first trimester and second trimester abortions. There are no hormonal side effects, can be used without consulting a health provider, easily available and protects against STDs, enables men to take responsibility of contraception. Next slide. Intrauterine contraceptive device. In case of first trimester abortion, it can be inserted immediately or up to 12 days after confirmation of a completed abortion. So when you call on day 15 for follow-up, you can insert IUCD. In second trimester abortion, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. It's highly effective. It provides protection for either 5 years in 375 or for 10 years in IUCD 380A. It can be provided by trained doctors, ANMs, nurses after first trimester surgical abortions, and by trained doctors only after MMA, and by PP-IUCD trained doctors after second trimester abortions. There's no interference with sexual activity. Immediate return to fertility on removal is possible. Next slide, please. Combined oral contraceptives. They can be started immediately or up to 7 days after abortion using surgical method. With MMA, it can be started on day 3 with the dose of misoprostol itself or within day 15 of the process after confirmation of completed abortion. After second trimester abortion, you can either start immediately or up to 7 days after abortion. It will also help in regulation of menstrual cycles. It can be provided by all the healthcare workers after first screening by trained provider. There's no interference with sexual activity. It offers protection against ectopic pregnancy, endometrial and ovarian CA, and benign breast diseases. It's not suitable for women who are breastfeeding babies less than 6 months old, since it can decrease lactation. Next slide. DMPA, it can be given immediately or up to 7 days after abortion using a surgical method. With MMA, it can be started on day 3 of your misoprostol because the patient might not come back to you on day 15. So make use of that second visit of MMA in order to advise contraception. Following second trimester abortions, either immediately or up to 7 days after abortion. It's highly effective. Confidentiality and privacy of the contraceptive method is maintained here. It can be provided by doctors, ANMs, nurses after screening by the doctors for the first injection. There's no interference with sexual activity, no effect on the quality and quantity of breast milk, so it can be given to breastfeeding feeding mothers. There's no estrogenic side effects. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Next slide. Coming to the permanent methods, female sterilization. It can be performed after an abortion in the absence of any infection or severe blood loss concurrently or up to 7 days. Both mini-lap and laparoscopic sterilization can be done. With MMA, it can be done only after the first menstrual cycle because you need to ensure completion, because she might come back With pregnancy after, you have done sterilization because MMA would have failed and she would have continued that same pregnancy. So if you have given MMA for first trimester abortion, please do sterilization only after the next cycle. In second trimester abortion, mini-lab sterilization can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended, okay, after second trimester abortions, because the tubes will be edematous and the laparoscopic sterilization would have it would not be complete. The fallopian rings wouldn't have completely occluded the lumen of the tubes, or you wouldn't have properly, in case of coagulation, using bipolar cautery or whatever, the entire tube, the entire thickness of the tube, the lumen would not have got coagulated. So laparoscopic sterilization is not recommended after second trimester abortion, as early as concurrent or up to 7 days. It's a permanent method, highly effective, no effect on breastfeeding or sexual activity, no long-term side effects. It offers protection against ovarian cancer. In fact, salpingectomy, elective salpingectomy is being propagated in order to prevent ovarian cancer. Vasectomy performed on males independent of the timing and procedure of the abortion. It's very effective, permanent method, no long-term health risk and no interference with sex. However, the couple must use some other method for 3 months. Okay, next slide, please. The same thing has been put on a chart. Next slide, please. Next slide. Next slide. Next slide. Coming to teleconsultation and other technologies. Next slide. We have to leverage technology in the form of teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. Next slide. We have websites like Hamdo, social media, Ask Tanu, YouTube, infographics, helpline numbers, and patient education platforms. Next slide. What is SWOT of teleconsultation? The strength of teleconsultation, we all realize in the COVID times, it was where the doctors were approachable throughout the process. Confidentiality was maintained. The awareness could be given, spread out questions and answered at ease. The weakness of this teleconsultation is there's no face-to-face communication and you can't demonstrate various methods. Opportunity, it gives privacy and comfort to the patient. It's cost saving. The number of visits can be cut down. What's the threat? The missed opportunity, and there can be misdiagnosis sometimes. You could miss out on ectopic pregnancies. Next slide. Okay, application of components of comprehensive abortion care. First, you need to confirm diagnosis and the contraceptive need. Then you need to do the counseling through either Zoom or video conference. Then you need to do follow-up. You can either do a hybrid service, one visit and later on teleconsultation. So in MMA, we usually have 3 visits. This can be reduced to 1 visit by adopting hybrid services. Next slide. So the key message is, please realize the need of pre and post abortion family planning. So please insist that in the teaching hospitals, that all your PG students and interns make this a habit. Do counseling on contraception in post-operative rounds or postnatal rounds. So this should become a part of your routine care. Bring the couple on board and strive for 100% coverage. Capitalize on the basket and applicability in the pre and post-abortion period. Technology can be used as far as possible. The scope for entry in CAC services. The concern is, there's no proper policy. There can be malpractice, and the service costs will be borne by the doctor, and the access is a problem for people residing in remote areas. Adolescent reproductive health needs both online and offline counseling. Next slide. Thank you so much.
Yeah, dear members, any questions to add? we can, I think the speakers can take some questions. If anyone has any questions. Sriman, I think everyone has understood too well. So no questions.
There's some questions in the chat box. Sir.
The chat box. Let me see. I can't see.
Whenever a girl approaches you in pregnancy, you need to inform the police. That the onus falls on the doctor itself. Otherwise, the doctor will be held guilty. If you're in a moral fix, the parents are not willing to inform, and you are like just helpless. Just refer them somewhere. Don't document anything about the patient. It's ultimately go wherever they. And whenever you refer to a government hospital, it will be compulsorily made a POCSO. Even if you find a lady who has come for a for a ANC card as a primary gravida, but later, now that maybe she is like, say she's 18 years now and she was married 2 years back, that means she had sexual intercourse at the age of 16 years. That also again comes under POCSO Act. There are a lot of discussions going on to bring down the age of cutoff age of POCSO, because a lot of cases are falling between this age 16 to 18, where they're already married and husband and wife are living a happy life, and like we are becoming villains in their lives. I think shortly some law will come up.
Hopefully. Yeah, and we request all the participants to take the post test so that you will receive your certificates.
Thank you, ma'am. Thank you very much.
Thank you so much, ma'am, for such an informative meeting.
Thank you. Thank you so much. Please permit me to leave. I have an emergency to attend.
Yes,
Thank
yes,
Okay,
me too.
ma'am.
Thank you. Thank you very much.
Okay, ma'am.
Thank you all. Yes, thank you, Sriman.
Welcome, ma'am. Welcome, ma'am.